Imagine being told that the cure for a severe, life-altering medical condition is to just walk into a clinic, sit fully clothed in a sleek chair for about 28 minutes while reading a magazine, and then, just simply walk out.
Yeah, no scalpel, no anesthesia.
Right. No active effort on your part whatsoever. I mean, it sounds less like clinical medicine and more like, I don't know, a late-night infomercial or some kind of parlor trick.
It really does. It's a premise that invites immediate skepticism, frankly,
Oh, absolutely.
because when a therapy is entirely passive and, heavily marketed as this non-invasive miracle, your clinical radar just immediately goes up.
Which is exactly why you're here. But our mission today for you listening isn't to just buy into the marketing brochure. We are staring down a massive stack of peer-reviewed medical journals, clinical trial data from places like clinicaltrials.gov, PubMed, and Dove Medical Press. And we're going to use all of that to answer one highly specific question on this deep dive. Can high-intensity focused electromagnetic chair technology, which, by the way, you'll hear us call HIFEM, can it actually effectively treat stress urinary incontinence?
Yeah, and we're going to dive really deep into the actual neuromuscular science, right? The urodynamic data that proves these anatomical changes.
A hard proof.
Exactly. And crucially, we have to look at the severe limitations and conflicting studies that paint a much more complicated picture of what this technology can actually achieve long term.
Okay, let's unpack this. Because to understand how a pulsating magnetic field fixes a structural failure in the pelvis, we first have to look at why that failure happens in the first place.
Right, the root cause.
Yeah, and why the current standard of care is leaving so many patients just utterly frustrated. So we're focusing specifically on stress urinary incontinence, or SUI. And the sources show a staggering prevalence here. I mean, somewhere between 25 to 45% of women experience this.
It's incredibly common, and it's triggered by physical exertion. So, a sudden spike in intra-abdominal pressure.
Like coughing or laughing.
Exactly. Coughing, laughing, sneezing, or jumping. That pressure suddenly overpowers the closure pressure of the urethra, resulting in a leak.
Okay, so anatomically, what is actually failing there?
Well, the biomechanics here are essentially a structural equilibrium issue. So the skeletal muscles of the pelvic floor, they form this supportive hammock for the bladder, the urethra, and other pelvic organs.
Okay, a hammock. I can picture that.
Right. And when that hammock suffers microtraumas or degradation, which, by the way, the data shows correlates heavily with advancing age, higher body mass index, and particularly parity, which is childbirth.
Right.
When that happens, the hammock loses its resting tone. The muscles literally just cannot muster the mechanical force required to pinch the urethra shut when that downward abdominal pressure spikes.
Wow. Which, I mean, that brings us to the immense frustration of traditional treatments, right? If you look at the clinical pathways in our sources, on the extreme intervention side, you have suburethral sling surgeries.
Yeah, and those are no joke.
No. The literature makes it very clear that invasive surgery carries substantial risks. We're talking chronic pelvic pain, severe infections, or even urethral or bladder perforation.
Which is terrifying for a lot of patients.
Exactly.
Yeah.
So because of that, the conservative gold standard is pretty much always pelvic floor muscle training or PFMT.
Yeah.
Kegel exercises.
Right, the classic recommendation.
But here is the statistic from the clinical data that just completely reframed this for me. Between 30 and 50% of women who are actively trying to do these exercises perform them incorrectly.
Half of them, yeah.
It's wild. It's like being told to flex a muscle you can't even visualize, like trying to wiggle your ears. If you can't feel the connection, how are you supposed to train the muscle?
That is a perfect analogy. And that failure rate is a direct reflection of degraded neuromuscular pathways. I mean, if you are listening to this and you have ever tried to actively rehabilitate a muscle group that you can't visually see or easily feel, you know exactly how vague the process is.
You just end up guessing.
Right. If the brain's connection to those specific motor neurons is compromised, you just can't voluntarily isolate the muscle. You end up bearing down on your abdominals or flexing your glutes instead.
Which does nothing to help the pelvic floor.
Exactly. It does absolutely nothing to improve the urethral closure angle. The command from your central nervous system simply isn't reaching the target.
Man. And that neuromuscular disconnect is the exact void this new technology claims to fill. So enter the BTL M-Cella chair, utilizing HIFEM technology. And we really need to talk about the physics here, because this isn't just some vibrating massage cushion.
No, not at all.
The chair actually contains a circular coil that emits a 2.5 Tesla magnetic field. And just for context for everyone listening, that is the exact same magnetic strength as a clinical MRI machine.
Yeah, it's incredibly powerful.
And it's concentrated directly into the pelvic floor.
What's fascinating here is how it leverages Faraday's law of induction to basically bypass the brain completely.
Okay, break that down for me, Faraday's law.
So, a really common misconception is that the chair is shooting electricity up into the body.
Which sounds awful.
Right. But it isn't doing that. According to Faraday's law, a rapidly changing magnetic field creates an electric field. And because magnetic waves pass completely unimpeded through clothing, skin, and fat.
Which is why you stay fully clothed.
Exactly. This 2.5 Tesla field penetrates up to 10 centimeters deep directly into the pelvic cavity. And once inside, the conductive tissues of the body, so your nerves and muscles, they actually generate their own internal electrical currents in response to that magnetic field.
Wait, really? So my own tissue is generating the current that forces the pudendal nerve to fire?
Yes, exactly. That internal current depolarizes the motor neurons directly. It literally doesn't matter if your brain knows how to isolate the pelvic floor or not.
Wow.
The central nervous system is entirely cut out of the loop. The magnetic field forces the nerve to fire, and the muscle is forced to contract.
Okay, I want to look at the sheer scale of those contractions, though, because the trial specifications we read are frankly mind-bending. A single 28 to 30-minute session on this device triggers approximately 11,000 to 11,700 intense pelvic floor contractions.
It's a massive amount of work.
I mean, a patient is literally just sitting there reading a book,
Yeah.
and their internal anatomy is executing over 11,000 physically perfect contractions. But the sources use this specific term that gives me pause. They state HIFEM induces supermaximal contractions. I need you to clarify this because if a maximal voluntary contraction, MVC, is the absolute hardest, my brain will allow me to squeeze a muscle. That limit exists for a reason,
Oh,
right?
absolutely. The nervous system acts as this highly evolved biological governor.
Okay.
When you execute an MVC, squeezing with every ounce of willpower you have, you can only hold that peak tension for a tiny fraction of a second before the brain forces the muscle to relax.
Right, you just physically give out.
Yeah, and it does this to prevent structural tearing and muscle damage.
Exactly. So I'm stuck on the biological safety of this whole thing. If my brain has a governor to stop me from tearing a muscle, and this magnetic chair bypasses that governor to force tension higher than my biological limit, 11,000 times in half an hour.
Yeah.
Why isn't the pelvic floor just ripping itself apart from all that mechanical stress?
It's a very valid question. It is a massive physiological stressor, no doubt. But skeletal muscle is extraordinarily adaptive when pushed past its normal threshold, provided the stimulus is controlled.
Okay.
Because the magnetic frequency is so high, the muscle fibers literally don't have time to relax between pulses. They are held a state of supramaximal tetanus.
Supramaximal tetanus, okay, meaning they're just locked up tight.
Right. And to survive this extreme environment without tearing, the tissue launches an aggressive, two-pronged cellular defense mechanism. It recruits both fast-twitch and slow-twitch muscle fibers simultaneously.
So it's forcing an adaptation rather than just causing a severe injury. What does that cellular defense actually look like, under a microscope?
Well, first, you see profound hypertrophy, which is the thickening and strengthening of your existing muscle fibers.
Like going to the gym.
Exactly.
Yeah.
But more importantly, the extreme load triggers hyperplasia.
Hyperplasia, what is that?
So the local cellular environment is stimulated to synthesize entirely new protein strands, creating brand new muscle fibers.
Wait, brand new fibers.
Yeah. The pelvic floor is physically expanding its cellular footprint. And simultaneously, because that pudendal nerve is firing thousands and thousands of times, you get this intense neuromuscular reeducation.
Oh, because the pathways are being forced to work.
Right. The neural pathways that were dormant or degraded are essentially shocked back into high-efficiency transmission.
That is just an incredible biological theory, bypassing the brain to force hyperplasia and neural reeducation. But I want to pivot to the actual fallout of this condition for the patient, because building thicker tissue is only relevant if it translates to the real world,
Absolutely. The clinical outcomes are what matter.
Right. We have to look at what the hard data shows when these patients actually leave the clinic. Let's look at that MDPI study in our stack that was tracking absorbent pad usage.
Oh, yeah, those numbers were striking.
Over a 6-month period following the treatment, patients' pad usage dropped drastically. Yeah. They went from an average of 4.2 pads a day down to just 0.6 pads.
The clinical significance of that drop really cannot be overstated. I mean, from a patient perspective, absorbent pads are a purely passive Band-Aid.
Right. They don't fix anything.
No, they don't treat the structural failure at all. They just manage the fluid.
And the sources highlight the severe physical toll of that management. I mean, we are talking about chronic incontinence-associated dermatitis.
Yeah, the skin issues.
Yeah. Severe skin inflammation, breakdown, and pain just from the tissue being in constant contact with trapped moisture.
Yeah.
So getting a patient from 4 pads down to essentially 0, that fundamentally changes their daily physical comfort.
It changes their whole life.
Yeah. And there's another retrospective study here focusing specifically on Paris women who have given birth,
Mm-hmm.
and they saw a 75% overall reduction in pad use across the whole cohort.
Mm-hmm.
Furthermore, looking at the ICIQ-SF questionnaire data from the studies, 21% of those subjects achieved complete total continence. 0 leakage.
Getting a fifth of a trial cohort to total continence with a totally non-invasive passive therapy, that is highly unusual in this field.
But here's where it gets really interesting, though, because it's one thing for a patient to fill out a survey and say, I'm leaking less. Subjective data is notoriously noisy.
It is. People want to feel better, so they report feeling better.
Right. But the sources provide objective urodynamic proof that the anatomy is physically altering. This isn't just patients feeling more confident. Machines are literally measuring the structural change.
Yeah, the urodynamic and ultrasound findings completely strip away any placebo effect here. Following a standard course of HIFEM treatment, researchers are measuring significant increases in the maximum urethral closure pressure, or MUCP.
So the physical strength of the mechanical seal holding the urine back is measurably higher.
Exactly. And they also noted an increase in the urethral closure angle.
The geometry of the pelvis is righting itself.
Right. As the muscle hypertrophies, it literally pulls the anatomical structures back into their proper alignments. But I think the most undeniable visual evidence comes from the ultrasound topography studies.
Oh, the levator hiatus measurements.
Yes. When you look at the pelvic floor on an ultrasound, while the patient is instructed to bear down, so simulating a hard cough or a laugh, you are evaluating the levator hiatus.
Which is the literal opening in the pelvic floor musculature that the urethra and other organs pass through.
Right. Under stress, a width in levator hiatus will widen, and that allows the bladder neck to drop and urine to escape.
Makes sense.
But on these post-treatment ultrasounds, you can literally watch the hiatus area shrink. The resting area is smaller, and the gap, when they are under intense abdominal stress, is significantly reduced. The newly generated muscle tissue acts as this reinforced mechanical barrier.
Okay, man. And when you reinforce that barrier, the psychological relief is just immense. The sources track scores on validated metrics like the ICIQ-SF and the King's Health Questionnaire, and the data shows these scores just plummeting after treatment.
The anxiety drops completely.
Yeah, I mean, if you've ever avoided a social event or stopped going to the gym or feared laughing in public because you couldn't trust your own body, you can imagine what it means to get that structural integrity back.
It restores physical autonomy, which is arguably the most valuable outcome in any rehabilitative medicine.
It is. It really is. But this is exactly where we need to apply the brakes.
Yes. The reality check.
Because it is very easy to get swept up in these high-tech, FDA-cleared success rates. But our job on this deep dive is to look at the conflicting data, too.
Right. There's always a catch.
There's a specific pilot study in our stack from MedCrave, conducted at a Portuguese hospital, that throws a major wrench into the longevity claims of this therapy.
I'm glad you brought this one up.
It was a small prospective study, only 11 women, but they underwent the standard 6 sessions on the HIFEM chair. And predictably, they saw immediate, significant subjective improvement.
Right.
But the researchers tracked them for a 3-month follow-up. And by month 3, their ICIQ, SF, and King's Health Questionnaire scores had reverted almost entirely back to their baseline. They lost the progress.
Yeah. If we connect this to the bigger picture of neuromuscular physiology, that regression makes absolute sense.
Really?
Oh, yeah. Skeletal muscle obeys a very strict, unforgiving rule of biological efficiency. Use it or lose it.
Use it or lose it.
Okay. If you spend 6 weeks at a gym lifting heavy weights, you will induce hypertrophy and hyperplasia. You'll build muscle. But if you stop entirely and sit on the couch for 3 months...
You lose the gains.
Exactly. Your body will break down that metabolically expensive muscle tissue. It will atrophy.
So for a subset of patients, the effects of the magnetic chair are entirely transient. It is not a permanent one-and-done cure. It is a massive, temporary biological jumpstart.
That Portuguese pilot study exposes the critical necessity for long-term maintenance. I mean, you cannot subject the pelvic floor to supermaximal stress for 3 weeks and then assume it will maintain that resting tone forever without any further stimulus.
Right.
This necessitates booster sessions or a structured transition into active therapy.
But see, that brings up a massive issue with the data itself, because the literature repeatedly mentions considerable heterogeneity across all these trials.
Yeah, they are all over the place.
Researchers are using different protocols, different session frequencies, and measuring different urodynamic endpoints. As a listener trying to evaluate this for themselves, how are we supposed to know what the actual gold standard of care is right now when the science itself seems incredibly fractured?
Well, the heterogeneity is the primary limitation of the current research landscape. The protocols are absolutely still being debated and standardized as we speak.
So,
Currently, the FDA-cleared baseline protocol generally sits at 6 sessions done twice a week for 3 weeks.
okay, so 3 weeks to start.
Right. But the literature lacks total consensus on the maintenance phase. Whether a patient requires a booster at 3 months, like that Portuguese study suggests, or at 6 months or even a year, it appears to be highly dependent on individual baseline tissue quality and lifestyle factors.
And we also need to confront the side effects here too, because this is heavily marketed by clinics as a completely painless, effortless lunch break procedure.
Which is slightly misleading.
Yeah. Yet Ismail and colleagues reported in their trial that over 50% of their female patients experienced some form of side effect. They documented leg, abdominal, and back pain alongside tingling sensations.
And while it is marketed as non-invasive, we have to remember the mechanics we discussed earlier.
The supramaximal contractions.
Right. You are violently depolarizing a major nerve network and forcing a muscle group to contract 11,000 times beyond its biological limit. Some peripheral nerve or referred muscle pain into the lower back and legs shouldn't be surprising at all.
Because it's basically a crazy workout.
Yes, it is a profound manipulation of the neuromuscular system. It is highly comparable to the intense delayed onset muscle soreness or DOMS you would experience after a grueling physical workout.
And there are hard biological stops here too, like the contraindications are severe, because this technology relies on a massive 2.5 Tesla magnetic field. Anyone with a pacemaker, any metal implants in the spinal cord, hips, or pelvic area, or anyone who's pregnant is strictly barred from using this chair.
Yeah, the magnetic field would interact dangerously with those implants.
Right.
And those limitations really force us to reevaluate how we position this technology within the broader landscape of pelvic health. HIFEM shouldn't be viewed as a silver bullet that completely replaces bodily awareness.
Okay, so what's the optimal way to use it then?
Well, when you look closely at the randomized controlled trials in our stack that compare different therapeutic approaches, the absolute most robust, long-lasting results don't come from the chair alone. They come from a combined multimodal approach.
Meaning you combine the passive magnetic chair with active traditional exercises.
Exactly. Using HIFEM as an adjunct to supervised pelvic floor muscle training is where the clinical magic actually happens.
Okay, that makes a lot of sense.
Right. You use the sheer brute force of the 2.5 Tesla magnetic field to wake up those dormant motor neurons and physically build the new muscle tissue through hyperplasia.
The jump start.
Exactly, the jump start. But then you use supervised physical therapy to actually teach the brain how to recruit and control that newly built muscle. You have to bridge the gap between the passive magnetic stimulation and your active human neurology.
Which perfectly distills the journey for you listening today. We set out to determine if a magnetic chair could effectively treat stress, urinary incontinence. And looking across the urodynamic data, the pad tests, and the cellular science, the answer is a definitive yes.
Yeah, the data's clear on that.
HIFEM technology is a legitimate, highly effective clinical tool. It successfully exploits Faraday's law of induction to completely bypass human error, forcing the pelvic floor to rebuild itself through supramaximal contractions.
It generates measurable structural changes in the pelvic anatomy that dramatically reduce fluid leakage and restore a patient's quality of life. Provided, of course, the patient commits to the necessary maintenance protocols.
So what does this all mean? It means we have officially entered a new era of rehabilitative medicine. We now possess the technology to passively and safely re-educate our own neuromuscular systems when our voluntary efforts simply aren't enough to repair the structural damage.
And if we extrapolate the mechanics of what we've learned today, it leaves us with a rather profound concept to consider.
Yeah.
We've spent this entire deep dive hyper-focused on the pelvic floor, but we have established that this technology uses targeted non-invasive magnetic fields to essentially hack the nervous system, bypass the biological governor, and generate entirely new muscle fibers from scratch.
Right.
If we can do this safely and effectively in the pelvis, could this exact same mechanism eventually be scaled up?
What do you mean, like whole body?
Yeah. Could we design a whole-body magnetic field to reverse age-related systemic muscle wasting in the elderly? Or, could we deploy this technology in zero gravity to prevent catastrophic muscle atrophy in astronauts on long-duration space flights to Mars? The pelvic floor might just be the initial proving ground for a much larger revolution in human physiology.
Curing incontinence today and keeping astronauts strong in deep space tomorrow. Thank you for joining us on this deep dive. We'll see you next time.